Welcome to This Week in Allergy and Immunology. This week we're covering 10 notable papers spanning phenotypic shifts in chronic asthma and drug hypersensitivity, safety considerations in targeted immunotherapies, and clinical registries for rare immunologic conditions. Let's dive in. We begin with a critical look at how we diagnose and manage hypersensitivity reactions in pediatric populations, specifically focusing on non-steroidal anti-inflammatory drugs, or NSAIDs. Published in the Journal of Allergy and Clinical Immunology. In practice, a prospective study by Valluzzi and colleagues evaluated 336 children and adolescents with a history of hypersensitivity reactions to NSAIDs. Applying updated international guidelines and oral drug challenges, the investigators confirmed true NSAID hypersensitivity or allergy in only about 31% of the cohort, meaning they successfully removed the allergy label in 69% of these pediatric patients. Among those with confirmed hypersensitivity, the most common presentations were single NSAID-induced urticaria, angioedema, or anaphylaxis, which occurred in over half of the confirmed cases, followed by cross-reactive NSAID-induced urticaria, angioedema, or anaphylaxis in roughly 22% of cases. Interestingly, among the 232 patients in whom true hypersensitivity was ruled out, over 14% were diagnosed with either NSAID-exacerbated food allergy or NSAID-induced food allergy, phenotype strongly associated with sensitization to the peach allergen Pru-P3. The researchers found that non-hypersensitive reactions were strongly linked with younger age, the presentation of urticaria, and the use of antipyretics, which carried a nearly six-fold increased odds of being non-allergic. This suggests that many reactions occurring during antipyretic use are actually related to the underlying viral infection rather than a true drug allergy, highlighting the clinical value of proactive drug challenges to avoid unnecessary drug avoidance. This theme of evolving phenotypes and the need for precise biomarker characterization is also evident in the management of severe asthma. A study analyzing data from 411 adults in the UBIOPRED cohort and validating their findings in 474 patients from the PRISM cohort, Yang and colleagues demonstrated that a longer duration of asthma is associated with a distinct shift in airway inflammation. Specifically, patients with a longer history of asthma exhibited significantly higher levels of non-type 2 sputum biomarkers, including elevated sputum CXCL9, sputum interleukin-6, and sputum neutrophils. Conversely, these patients showed a reduction in systemic and airway type 2 biomarkers, including lower plasma periostin, lower blood and sputum eosinophils, lower sputum eosinophil-derived neurotoxin, and lower fraction of exhaled nitric oxide. Clinically, this shift has profound implications in patients with an asthma duration of 20 years or more who were treated with anti-interleukin 4 receptor alpha therapy. Higher baseline sputum CXCL9 levels were associated with a significantly reduced rate of clinical remission at 12 months. These findings suggest that as asthma persists over decades, the underlying pathology may transition from a classic type 2-driven allergic response to a non-type 2 neutrophil-dominant inflammatory profile, indicating that combination therapeutic strategies targeting both pathways may be required for long-standing severe asthma. As our therapeutic arsenal for these allergic and immunologic diseases expands, clinicians must carefully weigh the efficacy of new agents against their safety profiles. Writing in the Annals of Allergy, Asthma and Immunology, Grogan and colleagues provided a comprehensive review of emerging monoclonal antibodies and small molecule therapies. While biologics targeting immunoglobulin E, interleukins 5, 4, 13, 31, and thymic stromal lymphopoietin are generally well tolerated, they are associated with specific adverse events such as anaphylaxis, conjunctivitis, eosinophilia, and herpes virus reactivation. The therapeutic landscape is further complicated by oral small molecule therapies, including Janus kinase, Bruton's tyrosine kinase, and PHOS-PHODIESTERASE4 inhibitors. Janus kinase inhibitors in particular carry boxed warnings for major adverse cardiovascular events, thromboembolism, malignancy, and viral reactivation. While second-generation Bruton's tyrosine kinase inhibitors and PHOS-PHODIESTERASE4 inhibitors offer more favorable safety profiles, tolerability remains a key concern for PHOS-PHODIESTERASE4 inhibitors. This underscores the vital role of shared decision-making and rigorous long-term surveillance in clinical practice, especially when transitioning patients to these newer, highly targeted systemic agents. Turning our attention to rare inborn errors of immunity, a landmark study in the annals of allergy, asthma, and immunology, introduces the first United States National Registry for female carriers of X-linked chronic granulomatous disease, known as the RAISE registry. Stuart Bates and colleagues collected data on 54 female carriers with a mean age of nearly 47 years. The findings reveal a stark clinical reality. Female carriers experience an average diagnostic delay of over 14 years from symptom onset, with a mean age at diagnosis of 27.7 years. 80% of the registered carriers reported clinical manifestations, with autoimmune or inflammatory conditions being more common than infections, affecting 62% and 53% of participants, respectively, and dermatologic issues often appearing as early manifestations. Laboratory evaluation showed a mean dihydrohodamine, or DHR, oxidative burst value of 22%. Crucially, among 10 carriers who underwent serial testing, the DHR value declined by a median of 2.35% annually, suggesting a progressive decline in neutrophil function over time due to skewed X chromosome inactivation. Despite these significant risks, the use of prophylactic antimicrobials and immunomodulators was highly inconsistent, even in carriers with active infections or DHR values below 20%, highlighting an urgent need for standardized monitoring and earlier intervention in this vulnerable population. The challenges of living with a rare, unpredictable condition are also highlighted in a study, which compared clinical courses and coping mechanisms across different subgroups of patients with angioedema. Leibovich, Nasi and colleagues evaluated 111 patients divided into 3 distinct cohorts: hereditary angioedema types 1 and 2 with C1 inhibitor deficiency, hereditary angioedema with a factor XII mutation, and angioedema of unknown cause. The investigators found that patients with classic C1 inhibitor deficiency had a significantly earlier mean age of disease onset, at approximately 10 years, compared to nearly 20 years for those with the factor XII mutation and 30 years for those with angioedema of unknown cause. Diagnosis was also achieved much earlier in the C1 inhibitor deficient group. Interestingly, despite experiencing an earlier onset of disease, patients with C1 inhibitor deficiency demonstrated significantly higher mean coping ability, higher overall quality of life, and superior resilience scores on the Connor-Davidson Resilience Scale compared to patients with angioedema of unknown cause or those with the factor XII mutation. This disparity suggests that established diagnostic pathways, patient support networks, and clearer management guidelines for classic hereditary angioedema may foster better psychological adaptation and resilience, whereas patients with newer genetic variants or unexplained angioedema face greater psychological distress and lower quality of life, pointing to a clear need for tailored supportive care. If you only have time for one paper this week, make it the prospective cohort study on pediatric NSAID-Hypersensitivity by Velluzzi and colleagues in the Journal of Allergy and Clinical Immunology in Practice. This study is a powerful reminder of the clinical impact of drug challenges, demonstrating that nearly 70% of children carrying an NSAID allergy label can safely have it removed, while identifying the critical, often overlooked phenotypes of NSAID-Exacerbated and NSAID-induced food allergy. Here are the key takeaways from this week in Allergy and Immunology. First, up to 69% of children with suspected NSAID hypersensitivity do not have a true allergy, and many reactions during antipyretic use are likely infection-related. However, clinicians must remain vigilant for NSAID-exacerbated or induced food allergy phenotypes, which are strongly linked to Pro-P3 sensitization. Second, severe asthma of longer duration is characterized by a significant shift away from type 2 inflammation toward non-type 2 neutrophil-driven airway inflammation, which may explain reduced responsiveness to type 2 targeted biologics over time. Third, female carriers of X-linked chronic granulomatous disease face a substantial diagnostic delay of over 14 years and may experience progressive neutrophil dysfunction, necessitating regular dihydrohodamine testing and proactive management. Finally, patients with angioedema of unknown cause or rarer genetic variants like factor XII mutations experience lower quality of life and poorer coping resilience compared to those with classic C1 inhibitor deficiency, highlighting the need for enhanced clinical and psychological support in these less understood subgroups. That's your roundup for this week in Allergy and Immunology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, Follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.